But finally, this patient has a good disease outcome. But please be reminded that don't forget the immunization, the vaccination schedule, the pneumococcal and influenza, which will help the patient in the long run, and they'll probably prevent a lot of infections. In case 2, is a young female with a liver issue, with a primary biliary cirrhosis. We can't use many DMARDs, but azathioprine HCQS is relatively safer. We can't use methotrexate, leflunomide, even SAS. But once it doesn't work, you have to go for biological treatment. We tried golimumab, but now she became pregnant. Now what do we do? So if you look at the EULAR recommendations for antirheumatic therapy in pregnancy, there are few drugs which we can use, which are safe during pregnancy, is hydroxychloroquine, sulfasalazine, azathioprine, tacrolimus, cyclosporin. The few biologicals are also safe, which could be used throughout the pregnancy, this etanercept and certolizumab. Because certolizumab is pegylated, there's a big molecule, they don't have a transplacental transfer. But if you look at a few more details, because various studies have shown TNF blocker cause some complications like preeclampsia, miscarriage, infertility. Infliximab could be continued till 16 weeks. Adalimumab could be continued till second trimester. But as I mentioned, etanercept, certolizumab could be continued throughout the pregnancy. But the only issue is if you consider TNF blockers till late pregnancy, then you can't use live vaccination for the baby till 7 months. So it's better to limit the treatment till first week of trimester. But in rituximab should be stopped 6 months before conception. So what we did, we stopped the adalimumab at 12 weeks, at the 3 months. She continued on azathioprine HCQS, and she had a good pregnancy outcome, and adalimumab was restarted after 8 months. So third case, here's the risk of infection. We need to know what is primary and secondary failure as well. And there's a risk of injection. I'm just rushing, I'm running out of time. There's quite a bit of infection risk among the biological treatment. But if you compare each of the anti-TNF, adalimumab, infliximab probably at a higher risk than the JAK2 inhibitors. They're relatively safer. Even rituximab is quite safer. There's a slight risk of TB reactivation as well. So what is or biological failure, which is primary and secondary failure? If there is no response within first 3 months, is classified as primary failure. And what are the causes? Probably the diagnosis is not right. Patient having osteoarthritis and fibromyalgia often been advocated biological treatment, they're not going to work. Or if a different pathogenesis, they're the 4 targets like TNF, IL-6. If the predominant pathway is IL-6, then anti-TNF is not going to work. So probably have to change the pathway. But in secondary failure, so from commonest cause is suboptimal dose. So you have to increase the dose to start with. Sometimes they develop, these are all protein molecules, so they can develop anti-drug antibodies. So that could be estimated, which we can't do it in India. Only few centers do it. So that would be visible, or you have to change either same pathway or different pathway. So what we did, we discussed abatacept and baricitinib in this patient, and she has chosen baricitinib, and she did really well. But not to forget the cardiovascular risk in rheumatoid. There's always a heightened risk of cardiovascular disease in rheumatoid arthritis patients.
Please try to conclude. Huh?
Thank you.
Because it's up time.
So basically, we have to modify the disease. Thanks very much.
Any questions from the audience or any comments on this topic?
It is printed biologics in rheumatology, but I think what was told to you, rheumatoid arthritis only.
Yeah, that was just told. I think usually seropositive patients are rituximab or adalimumab, but if it's a seronegative, you can do tocilizumab as well. But irrespective, if you think of the primary and secondary failures, I mean, IL-6 blockers is equally good.
If there is no question, we can go ahead for the next speaker. Thank you very much, Dr. Das.
Thanks very much.
So our next talk will be on, again, a very debatable and challenging subject, not just headache, understanding and treating the migraine. 2020. So that will be taken by Dr. Debashish Chowdhury. So Dr. Chowdhury, please keep in mind about the time because we are ahead in the lunch time. Yeah, that's okay.
I'll try to finish by that. ठीक है. So, namaskar, Professor Roy, Professor Ghosh, and Professor Udash. Thank you very much for the kind invitation. It's always a pleasure and an honor to come to your parent state and interact with all of you. And I know that there is a vibrant academic culture in West Bengal, so it's always been a pleasure. Now, sandwiched between the rheumatology and other neurological diseases, suddenly something has cropped up called headache and migraine. Headache has not been a primary concern for many of us during our MBBS curriculum or MD curriculum, or for that matter, DM curriculum as well. But unfortunately, if you see in general practice, then out of the 10 patients you see every day in outpatients, about 3 or 4 will be headache patients. So at least you have to know something about headache. So I'm going to share some of my thoughts on this headache, especially the migraine, and what it actually is unfolding. We are actually entering in a very exciting field. Just like in rheumatology, I was, so much biologics has come in, and it's just been coming in headache field as well. I'm going to talk about this migraine and what it will be landscape in the coming years in 2020s and beyond. So basically, for all of us to understand is that there are 2 types of headaches, the primary headaches and the secondary headache. If you see about 10 patients of headache, then about 9 out of them will be having a primary headache. And the primary headaches are 3 types: migraine, tension type headache, and the cluster headache. And then there are some uncommon forms. Don't bother about them. But the secondary headaches about 3 to 5%. And then there is a 1 to 2% cases of painful facial neuropathies, neuralgias, etc. This is by ICSD 3, which is a recent classification which was given in 2018, International Classification of Headache Disorders. Okay, but the most important of them is migraine, because migraine rules the headache and the disease world. Because if you see the global burden of disease, 1916, the Lancet study, it ranks 6th. And if you see of all the neurological causes, it ranks number 2, after the low back ache. So if you are actually practicing some sort of neurological practice as a physician or as a neurologist, you have to see migraine. So it is better to understand migraine in a better way. And why it is important? Because it's not only the most prominent, but if you see the years lived with disability, which is a very important marker for the disability, these patients do not die, but they're highly, highly disabled. So when a patient comes to you with migraine, I say, oh, doctor, I have a headache. So he said, oh, yeah, you have some headache, but, okay, do you have stress? Yes, lifestyle modification you have to do, and then forget about it. But they do have a lot of disability, and migraine is number 2 in terms of the disability as well. So therefore, you have to remember that if you want to treat and get these patients well, you have to understand this disease process a little better. If we have the epidemiology from India, one epidemiology study from Karnataka, and it was a very well conducted WHO conducted study, and it was about 25%, even higher than the Western figure, which is about 17% 1-year prevalence rate. One report from Calcutta in eastern India, and that has shown to be about 14%. So there might be differences in India about the prevalence of migraine and headache disorders, but then by and large, we Indians are much more predisposed to headache, and that has been seen in the Asian countries. We have seen the figures from Pakistan, from Nepal, from Sri Lanka, and the figure is around about 25%. So therefore, we are more prone to migraine headaches. What about the clinic-based studies? If a patient comes to your clinic, so we said, oh, don't forget about the community. What happens to the clinic? We have analyzed about 1,000 cases of our cases in the last 1 year, 2 years in fact, and out of that, if you see that 90% are primary headaches and 4% are secondary headaches. 83% of the primary headaches are migraines, and out of that, 1/3 are actually chronic migraine, which is a very, very disabling disorder. And then you have about 3.5% attention type headache and about 5% about tax, including the cluster headache. So this is the usual scenario, and rare primary headaches 1%. So therefore, you have to understand migraine very well, because these are the patients you are going to see day in, day out. So first important thing is that migraine is just not an headache, because it has got phases. Before the headache actually starts, many patients, as high as about 50 to 60% of patients, may complain of a pre-headache or pre-monitory symptoms, which may be mood changes, fatigue, cognitive changes, muscle pain, and food craving. Then about 1/4 of the patients in Western world and about 15%, 10 to 15% in our country, patients may have an aura, which might be the most common is the visual aura, the scintillations, the bright flashes of light which starts, and then there is a scotoma which slowly builds of the hemisphere field over 15 to 20 minutes, and that is the visual aura. So they may have that, and then the headache slowly starts, and it's a bell-shaped curve, and it goes on, and then it becomes an advanced headache with unilateral throbbing, nausea, photophobia, phonophobia, osmophobia. And even if the headache is gone, either due to treatment or by natural course, there is a postdrome. The patient doesn't feel well, there is a fatigue, there is cognitive changes, there is muscle pain. So it's a syndrome, it's just not the headache. There are a lot of things inside that headache spectrum. And also, there are a lot of other symptoms which go in and around migraine. There are sensory dysmodulation. The patient may complain of a lot of pains in the muscles, in the joints, in the neck. There are a lot of autonomic dysfunctions. There are cognitive dysfunctions. The patient says, doctor, during the headache or at the start of the headache or even after the headache, I just can't do my work. I cannot concentrate. I cannot calculate. I cannot solve a problem in the school for the children. And then there are various mood changes, changes of the affect, the depression, the anxiety, and the fear of the next attack again happening, catching you in surprise. So those things actually go and make the migraine treatment and the migraine diagnosis very, very complex. And more importantly, here, this is the point I want to highlight, is this, that now there is an increasing evidence that the migraine and the risk of cardiovascular and cerebrovascular disorders. This is a large Danish population-based study which has shown that migraine was associated with increased risk of myocardial infarction, ischemic stroke, hemorrhagic stroke, venous thromboembolism, and atrial fibrillation and atrial flutter. So migraine is an important cardiovascular risk factor disease which is associated. So when a patient comes, you have to need to look at them from that manner. Earlier, it was believed that only the migraine aura people are predisposed, but now there is increasing evidence that even migraine without aura people are equally important for these kind of risk factors. You see that there is also a correlation of hypercoagulability, which has been shown by elevated estrogen states, thrombocytosis, erythrocytosis, elevating circulating levels of von Willebrand antigen, fibrinogen, TPA antigen, and EMP. So therefore, there is a close association of migraine and the atherosclerotic risk association. In fact, we did a study in our department, and we found that whether the migraine patients have increased prevalence of vascular risk factors than normal healthy controls. And we analyzed actually 14 characters like clinical, biochemical, and radiological, including the carotid intima thickness and the CT coronary calcium scoring. And what we found that if you see the composite score out of this, the migraine patients have a statistically significant number of atherosclerotic risk associations as compared to the control. So this is now a very important emerging fact, and which all should be very, very careful about it. A little bit about pathophysiology. Now, migraine, you have to understand, is no longer called a vascular disease because it is primarily a brain disease. So you have to understand this, that what happens to the brain. And the initial activation, which has been actually shown in the premonitory phase by this Peter Gotts's group paper, which got the award for this particular paper, actually shows the hypothalamus is lighted up during the initial phase of the disease. So the hypothalamus is the principal orchestrator of migraine attack. So initially the hypothalamus lights up. And then there is this visual aura, the Hasikani group, which has shown that there is this aura which progresses from the back of your head over a period of time with the changes in the CBF, the cerebral blood volume. And if you see that initially, because of this high increase in the cerebral volume, there is this scintillations and positive symptoms. And then when it goes into the oligemic range, it goes to the dark scotoma. So that is the genesis of visual aura, started with a cortical spreading depression. And then finally what happens that because of this, there is a stimulation of meningeal blood vessels. The meningeal blood vessels are pain sensitive. They send the pain signals to the trigeminal ganglion, and to the trigeminal ganglion is got to the spinal nucleus of trigeminal at the at the back of your head, and then from that it goes up to the brainstem where there are pain modulating structures, and from there it goes to the thalamus, and from thalamus to the cortical areas. The initial concept was it was going only to the pain sensitive somatosensory cortex, but now there is increasing evidence that these are actually going to various places, and that's why you are seeing those symptoms like motor weakness and hemiplegic migraine, like the insular, the affective component of the pain. Some people feel the pain is unbearable. Some have visual symptoms, the V1, V2. And some have a lot of other autonomic dysfunctions. So there is this ascending pathway of the trigeminal vascular activation. So it's basically a disease which starts in the brain and then spreads to the dural meningeal wall, and from there it goes into again to the central of the brain and then spreads over to the entire brain. So therefore it's a complex process, and we still don't know about the exact networking that is happening, and that is the focus of intense research nowadays. So what is the diagnosis? Diagnosis, ICSD says that, it's a broad statement, and it's very important to remember that it's an idiopathic recurrent headache disorder manifesting in attacks lasting about 4 to 72 hours. So the most important part is this 4 to 72 hours. It's a long duration headache, right? So you have to ask the patient that how much your each attack lasts without any drugs. So some of the attacks, when they have not tried the drugs, so most of the people say, oh, doctor, it lasts for the entire day or 2 days, if I don't take the drug. So I have to take the drug. I have to take the analgesics. The typical characteristics are unilateral location, pulsating quality, moderate to severe intensity, aggravated by routine physical activity. So the patient doesn't want to move around. The patient becomes vegetated, it tries to lie down, lights off, sound off. So that is the character of migraine, and associated with nausea, photo and phonophobia. Vomiting is uncommon. Vomiting does happen in some patients, and sometimes it gives relief to the patient, but it's only about 30% patients. But these are the most important symptoms. And if you see the diagnostic criteria, so these all need not be present, only 2 out of these 4: unilateral location, pulsating quality, moderate to severe intensity, and aggravated by routine physical activity. And out of this, nausea, vomiting, or both, or photophobia and phonophobia, either one of this. And the most important thing is that you have to rule out any other possible cause of a secondary headache. And how do you do that? You do that by doing the, ruling out the red flags or the warning signs. The easy way to remember for me is OCA, onset, clinical characteristic, C and A associations. So what is onset? Is a sudden onset, thunderclap presentation, always a secondary cause. Subacute, slowly progressive course, secondary cause. New onset headache, any person above the age of 50 years, always be concerned that there will be a secondary cause. Vomiting preceding the headache. If the patient, normally in migraine, the vomiting occurs at the peak of the headache or at the fag end of the headache. But if the vomiting is happening before the headache, then that's a red flag. Headache precipitated consistently by cough, sneeze, straining, sexual activity. Occurrence in the morning, early awakening, again a red flag. Then headache characteristics in change of frequency or in change of character. Doctor, my earlier headaches was this throbbing type, and they were bilateral, and I was to feel nauseated. But now for 2 months I'm observing that I'm also having blurring of vision. Every time in the early morning I'm getting out, and it goes on regularly without any remission, change in character. So be aware, it might be a secondary headache developing on the background of a migrainous headache, right? Side-locked headache. Now migraine, although it's classically described as hemicranial, the side usually shifts it, sometimes left, sometimes right. But now, if the patient is having a consistently side-locked headache, it's a relative red flag. And if the side-locked headache is associated with autonomic symptoms, which I'll show you in a moment, it's again maybe a red flag, and you might be dealing with something else. And headache associations, any abnormal neurological examinations, the fundus, the eye signs, the field changes, or little changes in the reflexes, mild cerebellar signs, all need to be seen. Fever or unexplained systemic signs, and the known illnesses like cancer or HIV. So these are the ways you will identify that these are the red flags and I need to investigate this patient further. The other primary headaches are 2 types which you'll see in your clinic occasionally. Tension type headache. Now this is a common diagnosis given, but believe me, the tension type headache is uncommon disorder, because most of the patients who are diagnosing a tension type headache are actually migraine, because these patients do not actually come to the doctor, the tension, because they are able to keep on their activity regularly. And the most severe form of headache that is known to humankind is known as cluster headache. In fact, I published I was the guest editor of this in the Indian Academy of Neurology. I called it the worst headache of humankind. And so this is important to diagnose because the treatment is different. So I'll show you two videos so that you know that what is cluster headache, because often it is read in the books, but actually when you don't see, you don't understand. So see this first video. This is a case of an episodic cluster headache. Sound please.
कितनी देर से शुरू हुआ है?
अभी 15 मिनट हुए।
अच्छा।
बुरा हाल हो गया ये।
So side lock, very severe.
तो सारे सिर में दर्द हो रहा है?
इसमें आधे में।
Unilateral.
और क्या क्या समस्या हो रही है? आंखों से पानी आ रहा है?
And now you see the cranial autonomic symptoms, the redness of eyes.
जोर पड़ रहा है।
But these are all short duration. 15 minutes to 180 minutes.
चेहरे में सूजन सी लग रही है, इधर की तरफ।
There can be an edema of the face, edema of the lid. There can be rhinorrhea. There can be slight ptosis. But this is side locked. And the most important thing is that the patient is restless. Unlike migraine, where the patient is vegetative. Now, restlessness can vary in cluster headache. So, patient says that when a patient comes to the doctor and says that, doctor, I become restless during the headache. So, we do not actually attach that much importance. But I'll show you some of the videos. We'll see that what restlessness means actually, And some of them are taken by the patient in their home, but some I have taken it from my, when they were either admitted or in the outpatients. So this is very important to understand. Now this is this person's home video. Now at night, and usually it happens at a periodic time, in clustering at periodic time in the year and in the day and the night, same time. Now he is writhing in pain. It is unilateral, the right side. But this is mild, I'll call it mild. I'll show you and he's showing to his wife that this is paining, started paining her, and it is usually in the V1 distribution. And there is slight watering you can see at the corner of his, inner canvas. This is another patient. Now he is much more restless. Now it is in the left side. He is crying out. And this is an outpatient. And this is an inpatient. So an adult man. So they're trying to give him oxygen. So the point is this, that so unilateral, side lock, short duration, occurring number of times in a day, and clustering over a period of time with autonomic symptoms. So you have to ask this. So average delay in diagnosis in cluster headache is 5 years. They have to visit on average 4 to 5 physicians or a neurologist to get the diagnosis, right? On an average. So don't miss that. But that is very, very important to understand. Okay. So managing migraine, what is new? I've got 7 odd minutes. So as you know, that you have to manage the acute attacks and you have to manage the prevention part, right? The patients who are having recurrent headaches, usually more than 4 per month, but it depends on the activity of the person does. So what are the drugs available for the acute headache? You know all this, details, but the most important, the tailor-made drugs had been the triptans. So there has been a meta-analysis a long back which has shown that there is not much difference between the triptans, but that was an old study. Some recent meta-analysis have been done which has shown that possibly the elatriptan, sumatriptan injectable and the rizatriptan are better than the rest of the treatment. So generally in my practice, in India, elatriptan is available, but it is not easily available. So what I do is that in my practice, I use a lot of rizatriptan, right? And rizatriptan gives a good result, but remember that if you are using rizatriptan, and if you're giving a preventive as propranolol, then the dose has to be decreased. The dose has to be 5 milligram instead of 10 milligram. Second problem is this, that you give one triptan, and if you don't ask and tell the patient about the triptan symptoms, then the patient will default. Why? Because in the first 2 or 3 doses of triptans, they usually have this, sense of constriction in the chest, a sense of, palpitations, some uneasy feeling. So you have to tell them that you take the triptan and rest, and then also there is a dizziness. Initially, it will pass off. It will be there for about 10-15 minutes, but it will pass off. And then within half an hour to 45 minutes, you'll get the relief from the pain. So that is the most important thing you have to tell to the patient. And of course, the contraindications are uncontrolled hypertension, severe peripheral artery disease, and any other vasoconstrictive syndrome if the patient is having. So the triptans are very good, and now the cost has also come down, so you can use triptans. But if you really want to use the analgesics, there is no problem. But the problem is that we don't tell the patient when to take these medications. So if the attack is occurring, so there is a process which is known as central sensitization. The neurons in the brain get sensitized to the repeated barrage of this information which I showed going from the brainstem up. So that is called central sensitization. And if the central sensitization occurs, then there is no effect on these drugs. So therefore you have to give it before it happens, and that is usually 30 minutes. So you tell the patient, you know that when the migraine pain is coming, when the throbbing has come, now it has started peaking, and you take it at that time. You don't wait, let's see that it will get off, No, don't do that. Because if you don't treat the pain effectively, there is every chance that it will go into chronification. And chronic migraine is very difficult to treat. So there is a recent meta-analysis which is done in 2016, and it has shown that in triptans, the L-triptan, and if you want to give analgesics, ibuprofen, they are the best from the comprehensive point of view of the meta-analysis. Preventive treatment. You know that there are a lot of conventional preventive treatments that are already available to you in the form of beta blockers, in the form of calcium channel blockers, flunarizine, in the form of antihypertensives like candesartan, and anti-epileptics like topiramate, gabapentin, and divalproex. So which one to select? That is an important question for the physician's mind. Again, there is a recent meta-analysis, and it has shown that the propranolol, amitriptyline, flunarizine, topiramate, valproate, and candesartan are all probably equally good, right? So the question asks that which one will you use? So I have a bias here, and I will accept it because of my long experience here, and I have got now about 7,000 patients onto my roll in my headache clinic enrolled. So we had a debate with the international faculty that choosing the first anti-migraine prophylactic, do you have a first among equals? Yes, I say yes. Why? The answer is propranolol. Propranolol is the best drug to be given because it is safe. It can be effective at a very low dose. Even 20 milligram per day, some patients respond. You have to go up, and in India, I go up to 160 milligram. If the patient is not settling on 160 milligram per day of propranolol, then the patient is unlikely to benefit from propranolol. So propranolol is a good, drug to start with. But of course, you have to see the contraindication. If the patient is having a heart failure or the patient is having a bronchial asthma, you won't give propranolol. But what is the 2020 treatment? Now we have got these maps. There are 4 maps: erinumab, eptizumab, fremizumab, and galcanezumab. Out of these, the 3 have been approved by FDA, and in India, it is going to come in 2020. I have done an international trial with the erinumab, and we are just launching the galcanezumab trial in India. And so the question is that, are they useful? There is evidence that they are at least useful as far as the old conventional drugs are concerned, right? So the efficacy rate is over 40 to 60%, is slightly better for galcanezumab. And if you see that there is one point that the placebo effect is to the tune of 30% in all these studies, which is very, very well-known fact in all migraine research. So therefore, it leaves credence to this, these trials which have shown that they are effective. But more importantly, in comparison to the conventional drugs, they are probably the side effect free. They are basically given once in a month or once in 3 months injections, right? So they are much easier to give. The only factor is the cost. And I'm told that in India it will be costing around 10,000 per month cost. But now I think many people can afford it. And if you can just get one shot, in a month and get your migraine off, so I think many people will opt for that. So, and after this, our trial with China, I think the cost is going to further decrease. So this is a new thing which is coming up, and I think in another 2 years' time, this will flood the Indian market. Another thing which happens in migraine is the evolution of migraine to a chronic form. As the disease becomes chronic, more recurrent, these features decrease. The photophobia decreases, the phonophobia decreases, the throbbing decreases. And then it becomes very difficult to treat these patients. So what are the evolving therapies? Now we are doing a lot of these GON blocks, the greater occipital nerve blocks, right? So we put 2 injections here, right, at the back with the steroids, with the local anesthetic, or otherwise only with the local anesthetic. The second thing, it has been proven now that botulinum toxin, if you give continuously over a period of time, the botulinum toxin is going to be effective, right? So only thing is that you have to keep on giving that every 3 months, and the patients will become much better. So there is a technique called preempt technique which we use. Then there are a lot of devices which have come up. This is the Kefali device, the supraorbital nerve stimulation. It's cost about 16,000 rupees. This helps in some patients. There is a transcranial magnetic stimulation which is being introduced in India. This will come. So the patient actually puts the machine at the back of the head, both as an acute treatment as well as a preventive treatment. Then there is a vagus nerve stimulation. There is a non-invasive vagus nerve stimulation you can have. It's called gamma core. So you can stimulate your vagus nerve by this process, and it has shown to be, helpful. Then there is an auricular vagus nerve stimulation by a device called a Nemo device that has been marketed in Europe. And then there are new forms of therapies in the form of intranasal devices, orally inhaled DHE, painless needles, and transdermal patches. So there are a lot to offer. Only thing is that you need to be interested. You need to be focusing on these patients, because these patients actually are suffering quite a lot. You have to be sensitive about that. So I conclude by that saying that migraine is just not a merely headache disorder. It has much more. It has got a lot of connotations, systemic connotations, right? It is an excited field of research. All the youngsters who are here, you can take up headache medicine and you will go far. I can guarantee that. Because this is an evolving branch in neurology. Plenty of options of treatment are available. You have to choose the right one, treat the patients well, and if you treat the patients well, then there might be cases where I think that I have seen few patients who are actually exclusively sensitive to chocolates and red wine, for example.
Yeah, and
Right.
cheese also.
Cheese also, yeah, various types of cheese.
cases of this migraine, you have seen this antiphospholipid antibodies.
Oh, yes, that's a very good question. So, so generally, antiphospholipid antibody syndrome is a special type where you see a lot of migraine type of headache. But I would say that, usually they are not diagnosed until unless they develop a neurological, syndrome. So if a migraine patient comes, we generally don't do a antiphospholipid therapy as a routine. So only when they get a neurological syndrome, then only. But it is a common cause. I mean, it is a reasonable cause. I'll not say common, but it is a reasonable cause.
Okay, thank you, Dr. Chaudhary.
Association of PFO and patent foramen novel and migraine.
Yes. So there has been a lot of debate about the association of PFO and migraine, and generally the prevalence rate of PFO in migraine patients is higher. It's about 1.5 to 2 times, but it is probably an incidental finding, right? So because closure of the PFO has not shown conclusively by randomized trials to, decrease the migraine attacks. So therefore, nowadays it is recommended that you just, there is no need to detect, only if the patient becomes symptomatic. Otherwise, then only you can, do that.
So excellent presentation, I should say.
Right.
That
So
actually
thank you,
you
Dr.
kept our
Chaudhary.
request. And just on a
Thank you very much.
small thing I want to ask you, because you are telling a very huge headache clinic. So last 30, 40 years we are also seeing the patients. But as neurologist, what I find very practical thing I am asking, how many patients with the classical scotoma, that means fortified spectra, serrated fortified spectra starting from this side, what you have shown, that you come across in your clinic? Because there will be definitely few cases. But we do not get these types of cases in our clinics. Classical description of the fortified
Correct. So the Western figure is to the tune of about 25 to 29% of visual aura. But with the classical, what he's asking, saying that classical fortification spectra. But India, most of the studies have shown that it is to the tune of about 10%. In our study, we have found that we just recently, did one study in which we actually saw that what is the visual abnormalities in migraine, right? Now, there's a lot of talk about, also visual quality of life in migraine, right? So this is to the tune of about 12 to 15% in this thing. So in India it is much less. We need to know it. This is probably genetically related. There are now about 40 loci genes. This is a polymorphic disease, 40 loci of genes that have been identified for migraine. And I think Indians have got some protection because they might not be having those genetic abnormalities. So we are seeing less of aura, and that's a good news because the people with aura, migraine with aura, are much more predisposed to this cardiovascular and cerebrovascular risk, especially the women who are having migraine with aura, who smoke, who take alcohol, and that number is not less nowadays. I can guarantee you that, right? You have to ask, many women nowadays are going out, they are working, they are smoking, they are taking alcohol, and they are also having, if they are also having migraine with aura, then they are at high risk of a fatal or a disabling cardiovascular event. And also those who are using oral contraceptives. So when a patient comes to you, young female patient with a migraine, because migraine is more common in females, you have to ask this, otherwise you'll miss it completely.
So thank you. Oh, Dr. Viswas has a question.
Excellent presentation. One question. I am a physician, so I feel it is difficult to differentiate between trigeminal neuralgia and cluster headache. Can you please?
Trigeminal neuralgia and?
Cluster headache.
Cluster headache, yes. So that's a very, very important question. So cluster headache, first of all, is a slightly longer duration headache. So minimum duration is about 15 minutes to 180 minutes, one thing. Secondly, the cluster headache distribution is usually in the V1, that's the first division of trigeminal nerve. The trigeminal neuralgia alone, involving only the first division, is very rare. It's only 10%. Usually it affects from V2 to V3 and then goes up. The duration is very less. It's about, the definition of trigeminal neuralgia as far as ICSD is about 10 seconds. Third thing is that in trigeminal neuralgia, the autonomic symptoms which are shown here, they are virtually absent. Very rarely they'll have a mild tearing or mild redness, right? And the fourth important thing, that they will have a more of a neuralgic component. Neuralgic component, and the pain will just run through that distribution. Whereas the cluster will have, you see that they were rubbing and they were doing that kind of a thing. Whereas, trigeminal neuralgia is called tic convulsive. Earlier the term was tic convulsive. And there will be a refractory period. There will be a refractory period. And this all will be triggered by specific triggers like eating, chewing, wind. Whereas a cluster, there are no such triggers. Usually the cluster trigger is that if they take alcohol during the cluster period. So these are the ways you can differentiate.
Okay, so we can conclude this session. Thank you very much again.
Thank you.
Parthajit, Dr. please, for the presentation. Yeah.